What? All right, good afternoon, everybody. I think we're going to get started here. Today is our Tuesday webinar series for healthcare providers. I am Tom Jean. I'm Deputy Health Officer and one of the Senior Health Advisors for our COVID-19 response. And we also have Dr. Ariel Smits here today and Dr. Catherine Livingston. And I think we'll also be joined by Dana Drum, who's one of our local health liaisons. So we certainly appreciate your taking the time out of your day to join us, and we also appreciate everything you're doing on the front lines. And we also do appreciate hearing your questions. So we're going to try to address some of the questions that we received from last time. So moving to the agenda here. Let me move that. Thanks. So our agenda for today is to go through, as usual, some of our epi updates, latest case counts and projections. Then we'll start talking about the latest testing updates to our guidance and also address testing of workers in congregate care settings. We'll talk about some questions, answer some questions that came up on medications for COVID-19. We'll discuss federal changes in opioid prescribing. And then address some more general COVID-19 questions and the healthcare workforce. So for the update on epidemiology, we don't have numbers yet today, but our latest numbers yesterday were 1,584 positive cases. And these are cumulative case counts, 53 deaths, and 29,537 negative tests in Oregon. So we're holding pretty steady at about a 5% test positivity rate. And again, we know that community transmission in the state of Oregon is broad, and the test results do not reflect the full impact of COVID-19 in the state. About a week ago, we started this interactive data visualization data dashboard that's linked from our website, healthoregon.org/coronavirus. And this is updated every day and shows the epi curve. This is the curve that we're trying to flatten, and it shows the hospitalized cases and non-hospitalized. And these are, to clarify, these are listed by date of symptom onset, and it's not reflecting the total number currently hospitalized. These are cases who are people who are hospitalized at any point during their illness. And a little bit hard to look at trends, but it looks like things are plateauing at the very least, and we may be starting to see a decline, but it's still a little early to conclude that. But nonetheless, encouraging that we're not seeing continued upward trend. Our daily ED visits for COVID-like, overall, as well as for COVID-like illness, continue to be at a lower level than normal, and on the next slide, I'll show you that our daily visits specifically for COVID-like illness have been decreasing and really quite sharply in the past week. We're down to about 1% now of all ED visits are for COVID-like illness. Now I'm going to move on to our latest projections. So you may recall that we have worked with the Institute for Disease Modeling up in Washington, who's been providing us modeling estimates using our Oregon case data and our hospitalization data to project the total number of infections that we are likely to see in coming weeks, as well as the effects on our hospital capacity. So our latest projections, and this was updated on April 10th, show one second here. These are projections for the next 6 weeks, assuming either continuation of our current social interventions, and that would be the blue line, or a return to some of the more moderate social distancing interventions back in prior to March 23rd. And you can see that it shows a pretty flat curve for the daily case counts, the daily people with cases. and then with our current interventions, and then a steep upward trend if we were to right now go back to where we were. And this is there were some changes to the model with the new data. We had a little more complete reporting of all of our hospitalized cases. So the increase in projected cases over the previous versions is due primarily to the number of reported hospitalizations that increased. And then in addition, some of the assumptions on hospital length of stay were changed and lengthened based on some of the data from our early cases. What we are seeing from the projections and the modeling is that the community mitigation measures that we have implemented have decreased transmission of the coronavirus by 55 to 75%. So that things really are making a difference. And then the total cumulative infections with COVID-19 in Oregon by the end of this model, about May 18th, would be approximately 17,500 with approximately 2,100 active infections at that time. And that's what's showing here. The blue line is showing 2,100 about at the end. Okay, on the next slide, this is showing the number of hospital beds and ICU beds, basically, that are expected to be filled. So the number of people needing care in the hospital will remain fairly flat with our current interventions, and potentially slowly decreasing, although you can see it's modeled to be pretty slight. The projected acute care, so that's just general hospital beds, and intensive care, the critical cases there, will remain below the available capacity in Oregon through this model period. So despite the increase from this updated model, we are still projected to be under our capacity. And of course, one assumption of that is that we have adequate capacity of PPE available to providers. So just in summary, I think the sacrifices that we're all making to stay home and stay alive are working. And at this point, they still need to be maintained in order to prevent a resurgence of spread. Moving on to some testing updates. We did update our testing guidance slightly. Relatively minor changes. The main thing is we called out childcare specifically and added that to the list of facility and group settings on the bottom there. And then we also added that whole group, people who care, people who are in a care facility or group living settings, including healthcare, including childcare and residential care, as well as corrections. Those people are now specifically listed as recommended for general clinical testing. So our recommendations to clinicians is that if you do have people in those settings, that you test them if they have symptoms, fever, cough, or shortness of breath. Those people were already in our list for testing at the state public health lab, so we're merely adding that to the recommendations for clinical testing. I also wanted to briefly summarize the types of testing within the two main categories here. So for PCR, which is the main testing going on right now, this is the test that looks for RNA from the virus. That's a respiratory tract specimen, so typically a swab from the upper respiratory tract. And there's kind of three main categories now of this type of test. We've got the high throughput test, and that would be like the Roche and Abbott machines that some of the larger hospitals and health systems have, as well as what's at our state lab. Then there's the rapid test that we're really hoping should be coming online around the state, and that would be the Cepheid, the BioFire, and Hologic, and others. These are tests that are generally an automated rapid PCR test with a 45-minute or so turnaround. And the reason those haven't been online yet is due to shortages in the supply chain for the COVID-19 cartridges. And then finally, there is the Abbott ID Now, which is a rapid test that's been approved for point of care. And the ID Now machines can be done point of care with the COVID test. And again, that is, we have two of those machines that we've distributed around the state. And the reason we've only got two is that, well, we have two machines and we only have 100 tests so far, unfortunately. So we're waiting to get more capacity from Abbott. And overall, I'd say our testing capacity is currently doing quite well in state. We have about the capacity for about 1,900 tests per day, including our state lab, all the hospital systems labs. That's not including the out-of-state testing through LabCorp and Quest. And then the second category, of course, is serology. That would be antibody tests looking at blood. There's two main categories there. There would be the ELISA, based on a traditional blood draw that is mainly the province of universities and research hospitals. And then there's the new rapid finger prick point of care tests. And so far, there's only one of those approved for clinical use under the FDA emergency use authorization. And to my knowledge, there are shortages of that. It's not actually practically available, or at least in Oregon, I'm not aware that anybody's able to actually use that, unfortunately, but we're hoping that changes very soon.
Hi, this is Dana Drum. Sorry, I'm a few minutes late. The door was locked. So I've been working some with our long-term care and congregate care partners, and wanted to talk with you some about some specific needs related to congregate care settings. So when we talk about congregate care settings, we're thinking about long-term care facilities, corrections, facilities in which people live who are medically fragile. They may have intellectual or developmental disabilities, homeless shelters, but where there are people living in a relatively confined environment. And there is a strong need to make sure that we're quickly identifying COVID-19 in these settings, because there are infection control is especially important. So one of the things that we are prioritizing is timely testing of symptomatic facility residents and staff. And while we can generally assure more timely testing for residents, because the facility is often the one sort of coordinating that testing, it's a little trickier for symptomatic staff, because likely they are seeking assessment and care and testing in the community. So we've been working with partners to figure out how to address this, and one way we are doing that is we have provided a letter to congregate care facilities that the facility, when they're notified of a symptomatic staff person, they can provide this letter. It is signed by the state health officer, and then someone in charge at the facility would also sign it and fill in the name and the facility name, to that the person, the healthcare worker, or the facility staff person could then give to their healthcare provider. And in the letter, it states that we really need timely testing. So we want turnaround for these tests within, ideally within 1 to 2 days. Because for facilities in which COVID has not yet been identified, we need to identify it quickly. And we know that sometimes you as a healthcare provider, you have your own labs that you use, and they may be able to turn something around quickly, but they also may not. And so this letter is really just a prompt to kind of ask you to please prioritize symptomatic congregate care workers for testing if in your assessment they have symptoms consistent with COVID-like illness. And the letter also provides information. So if your lab can't provide quick results, these symptoms, sure, these specimens can go to the state public health lab, and we would really encourage you to do that if you can't turn it around within 1 to 3 days. We have had reports that some providers have refused to send stuff to the state public health lab for these individuals, and then facilities and the staff are waiting like 7 days or more to get a test result, and that's problematic for use of PPE. It's problematic for a number of reasons. So we just want you to be aware that you may see one of these letters or more. We also kind of want to reiterate that, while most individuals you assess with mild symptoms, they likely may not need testing. They'll recover at home just fine. If the individual that you're working with is a congregate care worker, even with mild symptoms, we would want them tested quickly so that we can identify it and link it to the particular setting or settings in which they work, because a number of them, they often work in more than one facility. So we run the risk of not only one facility being exposed, but multiple facilities being exposed. So just wanted to make you aware that this letter is out there and you may see it.
Thanks, Dana. One of the questions we got from last week was about how do we ensure that frontline staff in mental health centers that are not tied to a hospital system can get testing, and that would this letter work in that setting? I mean, it's a congregate care setting.
Yes, we're working with our behavioral health colleagues within OHA to share this with, I'm not sure what the term is, but congregate sort of residential facilities, right? So it would, that it is in the process of being shared out.
Very good, great, thank you.
Mm-hmm. Thank you.
All right, we'll move on here.
So this is Ariel Smith. We've put in some information today about medications for COVID-19. This is in response to a lot of your questions. I want to put the caveat straight ahead that this is an incredibly rapidly changing field. There's lots of very smart people all over the world researching this and things being published daily. So this slide's already out of date, I will guarantee you. And before we start, just to answer the question that I know we've addressed a few times about ACEs and ARBs, this is unrelated to medication to treat COVID. So patients who are already on ACEs and ARBs, leave them on their ACEs and ARBs. Just to remind, that was a question that we got again this week. So these next two slides really are based on a JAMA review that came out this week. They agree with the Infectious Disease Society of America, who just also published guidelines on medications. There's been multiple medications that have been pulled to try to treat COVID. So these are actually things to treat COVID itself. I'm sure you've seen on the news and read studies about chloroquine and hydroxychloroquine. The sort of main data we have on these two drugs are two very small methodologically flawed studies. One with positive results, one showed no effectiveness, and serious adverse events were reported. There was no high quality evidence that these drugs worked for previous coronaviruses like the original SARS or MERS, but there are ongoing RCTs looking at these two drugs. So at this point, there's no recommendations to use these drugs other than in an experimental setting. Lopinavir, ritonavir, which is an HIV drug combination, no evidence of effectiveness and high rates of adverse events. So this is a kind of a dead end. No additional research appears to be going on in this area. Ribavirin, there's inconclusive efficacy data for other COVID type medications. And it has toxicity, so it appears to be of limited value for treatment for COVID-19. Remdesivir, it has potent in vitro activity against COVID-19. It's currently being tested in randomized controlled trials. The current dose under investigation is a 200 milligram loading dose and then a 100 milligram daily infusion. This is being very actively studied. Again, there's no recommendation to use it outside of an experimental setting, but hopefully this will end up showing positive effects. Estelmavir has not been shown to be effective. Olmefimavir is being studied in China and Russia, but is not currently available in the United States. Interferon alpha and beta have no data, and also nitaxonazide, which apparently has been looked at in China. That's a antihelminithic medication. The other recommendation that's been coming out is not to use corticosteroids in patients with COVID-19 infections. So unfortunately, the reviews so far and what the IDSA say are that there is nothing that we have other than supportive care at this point. We will continue to monitor the literature, and hopefully as the studies progress, if anything is found to be effective, we'll try to get that information out to you as soon as possible.
This is Kat Livingston. There have been some questions about opioid prescribing and how that should change due to COVID-19. So the DEA did issue policy that was effective March 31st of 2020 that generally allows for some relaxations around opioid prescribing. So the first is in patients who have been previously examined and are known to the provider in person. It is okay to use any method for evaluation. So that might be via MyChart or a secure email system, telephone, telehealth, or in-person visits. All of those would be considered acceptable in order to renew ongoing opioid prescriptions. For patients who have not previously been examined in person, if you are thinking an opioid might be indicated that would require an in-person or telemedicine audio video visit, it would not be okay to prescribe opioids newly for a patient who has not previously been evaluated by telephone only. For buprenorphine, if you're doing office-based treatment for opioid use disorder, it is okay to prescribe via telephone or audio video. Next slide, please. In terms of medication treatment or medication-assisted treatment, as it was formerly called, for opioid use disorder in opioid treatment programs, there have been some questions around this just in terms of increased takeouts for patients. So there is enhanced flexibility for OTPs to increase the duration of the dispensed methadone or treatment. So it can be up to 28 days for stable patients and up to 14 days for less stable patients. It's really important to remember, however, that the decisions are still made on a case-by-case level for individuals. So the kind of things that are factored into the decisions for OTPs deciding how much of the treatment to give at a time are things like safe storage. You know, do they have a safe place to store it, and is there risk either to themselves or others based on storage availability, as well as comorbid substance use. So there's this ongoing balance between patient safety and overdose risk, and then controlling the coronavirus spread. OTP clinics have definitely cut down on the traffic flow, however, as part of trying to prevent spread of COVID-19.
So this is Ariel Smits again. This section just responds to questions that you all sent us either during the webinar last week or afterwards, and thank you again for sending in questions. Some of your questions were hopefully answered with the information we've already provided. These are some additional questions. So we had several questions about providing well-person care. It's OHA's stance that if such care can be provided, if it does not require PPE, and you should prioritize time-sensitive care, such as those involving immunizations, and consider delaying well-person care if that can be done safely. Another question that was brought to us was what is the recommendation for return to work for food service workers or workers in congregate settings? There is no difference from the OHA guidance on other critical employees. You need at least 3 days, 72 hours, since resolution of cough and fever, and the fever has to be resolved without the use of fever-reducing medications, and at least 7 days has elapsed since the symptoms first appeared. The worker could consider wearing a face mask while at work for 14 days after symptom development. And as usual, all employees should adhere to hand hygiene, cough hygiene, and all other good measures, not touching your face, etc. As part of this, we had a question about this resolution. Should the cough have completely resolved, or could it have improved? We would like to have seen resolution of the cough and shortness of breath. There might be a slight residual cough that would be acceptable, but in general, we would like there to be no significant coughing. And then we just had some general information about the healthcare workforce. Next slide. People continue to ask us how to volunteer. The Serve Or organization is available, and you can see on the screen right now the website on how to sign up to become a volunteer with that organization. And as we've mentioned on previous calls, the Oregon Medical Board has updated information for those licensees with all, and it's Oregon Medical Board and all of the other professional boards. If you have recently retired or had become inactive within the past 3 years and you were in good standing at the when your license lapsed or retired, you can have your license reactivated, either through the Oregon Medical Board or through the appropriate board for your profession. So please look into that if you want to reactivate. And in closing, we have lots of information. You can see the OHA coronavirus information for healthcare providers. So in general, the www.healthoregon.org/coronavirus will get you to our general site, which has lots of great information for families, for employers, etc. If you add HCP at the end of that, you will get to the healthcare provider section. Again, we want to thank you for all the work that you're doing on the front lines, and we want to continue to be a source of information for you. If you have any questions, please email it to us or get it to us, and you can email healthcare.provider@dhsoha.state.or.us. Again, we cannot do any individual responses, and please don't include any PHI.
Protected health information.
Protected health information. We also want to remind you that Project ECHO has another call, which is a complement hopefully to this one. They hold this every week on Thursdays from 12 to 1. It's hosted by Dr. Haganani, who is the Chief Medical Officer of OHA, as well as Dr. Jennifer Vines of Multnomah County Health Officer, as well as invited content experts. And they provide the latest updates and share questions, etc. The one nice thing about the Project ECHO call is that there is live interaction between members. You can do it through the chat box feature. And so that can provide you a lot of crowdsourced answers to your questions. So I would highly recommend that you would take some time, if it works in your schedule, to listen in or watch the Project ECHO.
Agreed, and it's a little different format from this meeting, and I would say in this meeting we have obviously more time to cover different topics. So if there are topics we're not covering that you'd like to hear about, please let us know, and of course continue to send us your questions, and we'd love to answer them. Okay, well, thank you everybody for your attention, and we'll hopefully see you or not see you, but be broadcasting to you again next week at the same time, and we'll hope to see some of you on the Project ECHO call on Thursday. Thanks and have a great day.